screen. I think that is it. Yeah. All right. Thank you very much. Thank you for the kind introduction, and also thank you for this invitation. The topic that I've been asked to deal with you tonight is what does living well with kidney disease mean to me? That's of course a bit of a difficult topic to talk about. What is the perception of patients and what would make patients happy? So I will discuss this out of the perspective of the organization that I represent, which is the European Kidney Health Alliance. And just to explain, the European Kidney Health Alliance, or EKA, is a Brussels-based NGO that is defending the case of kidney patients and of the nephrological community at the level of the European Union and the national level. And we are representing not only the physicians, but also the nurses, the foundations, and above all, the patients. And we are very happy that we have the patients on board, because I think for advocacy, we need the support and the active contribution of the patients. And together with this, we have also 12 or 13 national societies that are affiliated members. The first thing I wish is that the European Union would pay more attention to kidney disease. Now it's off the screen, off the radar. You see here the list of the European Union key health areas, and you will see many other disorders that are linked to kidney disease, but kidney disease itself is not there. And of course, this lack of attention is reflected in the way of treatment and in the way progression is going quite slowly for the treatment of those patients. Then I would like to have more attention for patient-centered outcomes. Patient-centered outcomes have been neglected for many years. It's improving a bit the last few years, but we have mainly been focusing on outcomes and on survival, whereas these are things that are not directly killing patients, but are bothering them very much, affecting their quality of life, but also make them depressive, unhappy. And this is a problem that should be solved both from the understanding of the causes and also the therapeutic solutions. And I show you the example of itching, which is a much neglected symptom that is there in a substantial number of patients, but we do not know as doctors that it is happening just because we do not ask for it. But together with these, there are also a lot of other patient-centered outcomes, quite often related to neurological function and leading to depression, which are also very important. And all this is, of course, related to quality of life. And quality of life is affected by therapy. And once we are evolving towards renal failure, then this treatment is by dialysis or transplantation. And the dialysis strategy itself has a major impact on quality of life. Here is a study on the quality of life comparison between peritoneal dialysis and in-center hemodialysis. Each score that would be above 1 is favoring peritoneal dialysis. So you can see that there is a large superiority of quality of life for peritoneal dialysis patients. And one would expect that this therapy, for those reasons, is very popular in Europe, but it is not. There are only 12% of patients treated with peritoneal dialysis or with home hemodialysis. And I guess that this underrepresentation of peritoneal dialysis is there all over the world. Yet, if we are looking at individual European countries, then you can see there are huge differences. For instance, in Scandinavia, we are above 30%. At the other side of the spectrum, we have a lot of countries with a frequency among dialyzed patients of less than 5%. So these huge differences should somehow be reduced by countries lagging behind, taking example of those that have a superior position, so that Europe becomes more uniform. And the same can be told about transplantation. For transplantation, again, one would expect that this treatment is extremely popular because it improves quality of life, but also survival. And on top of that, it is also less costly to societies. But again, you see these huge differences among European countries, with a number of countries that are really below 10 kidney transplants per million people. And here again, there should be more harmony and a way that those countries are taken by the hand by the countries that are doing better, so that transplantation rate throughout Europe is improving. And this goes together with another problem, which is health literacy. Quite a lot of kidney patients are health illiterate, and that is a problem for most chronic diseases. Here you see the percentage in this meta-analysis of health illiterate among CKD patients before dialysis and then in the dialysis population. And you see that each time this figure is around 25 to 30%. For transplantation, it's a little bit better, but still there is a lot of health illiteracy, and that means that there is a need for better education of our patients. So the next thing I wish is that patients get better and more correct information about their treatment modalities. Here, for instance, is a result of a survey that we took with ECHA on the satisfaction of patients about the information that they obtained about peritoneal dialysis, and the red bars are indicating the patients that were dissatisfied by their education. So again, you see these differences among European countries, but on top of that, you see on the average that about 30 to 40% is dissatisfied. And in addition, you see that in some countries, like the Netherlands, where peritoneal dialysis is quite often exerted, the information is also relatively good, whereas in other countries where there is very little peritoneal dialysis, there is also very little information. So there is this sort of vicious circle whereby less information is provided if a treatment modality is not popular in that country. And in this way, we are turning around in some sort of circle. And if we are talking quality of life and therapy and home treatments, also I wish that home treatments become more simple, more flexible, and that it is possible for patients to move around more easily. And there are fortunately several efforts around the world to make home dialysis and home hemodialysis more compact. This is an example of what was previously called the Neo Kidney. It's an initiative from the Dutch Kidney Foundation, which is now called Next Kidney. And finally, I would like to have more awareness about kidney disease. You see here the frequency in 2019 of a whole set of chronic diseases and also a number of other diseases. But you see that chronic kidney disease really comes in the middle of the pack, and that we are anteceding actually chronic respiratory disease, diabetes mellitus, Alzheimer, and also HIV/AIDS, and those are all disorders that get more attention from the authorities and from Europe than chronic kidney disease. So we would like to have also more attention, the more that if we are looking at mortality data, then it is the only chronic disease where over the last decades the mortality was going up. All the others, mortality was going down. As a comparator, diabetes mellitus minus 32% and cardiovascular disease minus 52%. So we want that also this sad statistic is turned around, but that would mean that more effort and more money is going into research and innovation. So I wish also that this problem gets more attention. So this is my bucket list: more awareness, more attention for patient-oriented outcomes, more and better information to the patients, more home dialysis, more transplantation, more flexible therapies, and better outcomes. I thank you for your attention.
Uh, Thank you very much, Ray. A real and interesting presentation, and many things that is still to be done. And yeah, hopefully we will advocate for that. And of course, after the second presentation, we will have a little discussion about that and what do you see, what is our needs or our claims about the living well with kidney disease. So thank you very much, Ray. And I'm going to introduce you the second participant, the second presenter about the living well with kidney disease. He is the Professor Camilla Calantard. He is the president of the European Federation, the International Federation of Kidney Foundations. He is a member of the steering committee of the World Kidney Day. So he is able to explain to us why is the reason what he choose or they choose the slogan, the living well with kidney disease. He's a professor of medicine and public health at the University of California, Irvine School of Medicine, and he's triple board certified in internal medicine, pediatrics, and nephrology. So thank you very much, Cam, for your time, and good morning for you. And of course, the floor is yours, and we will have a discussion after you.
Thank you, Mr. Daniel Gallego. So I don't know if you see the slide. Do you see that? Excellent. So yes, it's such a great pleasure and honor to work with Daniel in Spain and in Europe, and also to acknowledge Professor Raymond Vanholder. He has been an important icon in nephrology, and I've been always learning from Dr. Vanholder all these years. Now, going back to World Kidney Day 2021, so as you see here, living well with kidney disease, and I would like to say hi to everybody from Southern California. We're in Los Angeles. In January, we had a major COVID coronavirus surge. It was like a war zone here. I was crying every day, not running out of dialysis machines, but now it improved since February, and I hope everywhere you are, please be safe, receive your vaccines, and let's continue, especially if you have kidney disease, you must have the highest priority to receive your vaccines. Now, International Federation of Kidney Foundations and World Kidney Alliance is one of the co-founders of the World Kidney Day, which was created in 2005. World Kidney Days this year is about living well with kidney disease. But what does this theme mean? Every year, World Kidney Day has a theme. I have highlighted here the themes of the World Kidney Days of the past 6 years, such as kidney disease in children, obesity, women's health, universal access, prevention, and living well with kidney disease. The reason is because we thought while one of our missions is prevention of kidney disease or things related to education, what about millions of people with kidney disease? And these are my patients. These are essentially people like yourself. I have like 60 dialysis patients. I see them every week, and I have to some of them, I have very close relationship. And after 20 years of practicing, I went to medical school in Germany. I also learned in Nuremberg. I practiced nephrology in Nuremberg, then went to New York and now California. And after 25 years, I've come to believe that for us doctors, there are things that we don't see. And I'm very happy we are in the new era of understanding what it means to live with kidney disease. It's something that is beyond telling our patients what's your dialysis numbers, what's your phosphorus, what's your hemoglobin. It's about quality of life. It's about how they live every day. So during my rounds, nowadays I ask them, how's your wife? How are your children doing? These questions for me have become actually more important than telling the patients your phosphorus is this or your albumin is that. And quality of life, as Dr. Vanholder says, is an important metric. That means, do I feel happy with what I'm doing? And do I know what my priorities and values and goals are? Otherwise, there is no reason to do dialysis or kidney transplantation. So to advance research, practice, and policies, there is an increasing recognition to identify patients' priorities. What is my patient's priorities? Not my priorities. It's not my job description to provide dialysis or kidney transplantation or CKD or slowing progression. I need to understand what my patient expects, and I need actually to help my patient to understand, right? As a doctor. Now, if you look at here, the kidney care chart is a lot of we nephrologists, we learned that start patients early on dialysis, right? This was something that we learned for 20 years. Now we say that maybe later is better or never dialysis. This is essentially, these are different concepts, the concept of supportive care, of never dialysis, the concept of life-sustaining care, earlier dialysis. But our patients are beyond this. They need something, you need something called hope. And you have it already. Otherwise, you would not be sitting here listening to this. You would not be trying to find out your options. Hope is the feeling of trust. And without hope, you wouldn't again be listening to me. So you're listening to me, you're celebrating World Kidney Day. It's because of the feeling of expectation and desire for a certain outcome to happen. And I'm quoting now Dr. Alison Tong's interviews with patients. I don't want to think about dying. I want to be able to live well, not just live, to live well with my disease. Could be another 10 years, 20 years, 30 years, 50 years, or 100 years. CKD lives with you and you control CKD. That's our goal. And to that end, we nephrologists and healthcare providers, we need to make sure that symptoms of our patients do not affect our patients. That means irrespective of type of kidney disease, we want a person with kidney disease to live well, maintain social functioning, protect the normalcy, and have control. So look at here. This is quite interesting that doctors, when they were asked, we nephrologists, we care more about, look at the bottom line, mortality, hospitalization, blood pressure drops, vascular access, whereas for patients, what is important? Ability to travel, dialysis free time. A lot of us going and pushing patients, you need 4 hours, 6 hours, 10 hours dialysis, daily dialysis. Yes, that's great. But what about patients' life? We need to understand post-dialysis fatigue, immunosuppressive medications for transplants that have so many side effects, and ability to work and to study. So therefore, this is essentially the highlight of World Kidney Day 2021, symptom management, very important. I mean, if a patient is still tired, in pain, cannot sleep, then it doesn't matter how great medication, immunosuppressive medication, dialysis therapy I provide. Strength-based approach, build resilience, increase awareness and knowledge, support, and then impact of life on work, travel, study, dialysis free time, dietary restriction, instead of telling what to not to eat, essentially there's nothing to eat, what eat well. And then clinical strategies should be based on, for those who have CKD, not on dialysis or transplant, should be based on slowing progression, delaying dialysis, improving cardiovascular health. And even when they start dialysis, we should start dialysis gradually, maybe once a week, twice a week, instead of saying that I want the best dialysis 3 times a week, at least 4 to 5 hours a day. Let's just do it gradually, incremental dialysis, preservation of kidney function. My patients want to still make urine, even if they're on dialysis. Yes, palliative care is important for somebody after 20 years, 30 years, 50 years of dialysis, but more important is symptom management, highlighting symptom management. So therefore, I would like again to highlight here involvement in life situations. And this is our message to the World Health Organizations, to kidney, to professional societies. Let's work with the governments with the concept of life participation. That means let's bring this to one of the metrics of all societies. So I think I went over some of these things. These are patients who I don't want to think about dying from the disease. I want to be able to live well with my disease. And let me go over another set of slides. Is the choice. We need our patients to have choices. We can't just say that either when patient needs dialysis, either you start dialysis or there is another one not to do dialysis and palliative medicine. We should give more than two choices, right? We should give to our patients as things such as conservative management to live even longer, expanded use of palliative care, that is symptom management, gradual transition to dialysis, as I discussed, gradual stop of dialysis, and among others, for example, highlighting palliative use of symptom management. Palliative approach is not for a patient to die. That is a wrong concept. It's for a patient to have symptom management. The symptoms, pain, fatigue, pruritus, as Dr. Banholder highlighted, nausea, vomiting, they should all be controlled well. Otherwise, patient cannot concentrate at work, cannot enjoy family members, and therefore, look at here, for example, an example, fatigue. 89 to up to 89% of patients after dialysis, they're tired. Sleep problems, pain, cramps on dialysis, pruritus, itchiness. And this is another very similar. I mean, all studies show the same thing. You can feeling tired, dry skin, trouble falling asleep, trouble sleeping, muscle cramps, constipation. And we nephrologists, we tend to just see the patient and make sure that the dialysis is done well, make sure that level of tacrolimus or Prograf is well, and then move on. And that is the one that we want with this year's message, to change it. Look at here, dialyze to live, don't live to dialyze. This is from a patient group. It's called renal support group. And I strongly hope that the keyword renal doesn't go away, because kidney is important, renal is important. In Spain, Italy, in so many countries, it's called renal. Even in California, as you can see, patients group is called renal support group. And this patient, Lori, who started dialysis as a child, and now she's, I think, 50 plus years old. She has created this group. And then this is another example. Dialysis means life. This is a patient who, at the age of 72, I think, started dialysis, when most people said that you should consider no dialysis. And then up to the age of 79, she lived well. And she, I'm sorry, I said she, I'm sorry, that's the lady behind her. That's the another patient. But this gentleman, he started actually dialysis at the age of 72, similar to that lady. And they both, and she's still alive, and he passed away last year, but he created Dialysis Means Life. Dialysis Means Life, because he showed to patients how to enjoy kidney transplant and dialysis. So if you want to, so let me see if I go to my summary. In conclusion, effective strategies to empower patients and their care partners. And I didn't have time to talk about care partners. Care partners are caregivers. Caregiver is a correct word. But a care partner is also involved. That means you're not paid to provide care. Your life is affected by the life and disease of your husband, of your wife, your father, your mother, your children, right? So you are not just a caregiver, you're a care partner. And we need to minimize burden of CKD on patients and care partners. We need to empower them to be in control. And we need to come up with strategies to reach to that end. I mean, shifting towards strength-based approach, changing nephrology, and 2021 is the year to go to reach those goals. And whereas World Kidney Day continues to emphasize importance of prevention of kidney disease, and it's very important for your family members and your friends. When you have kidney disease, we need to make sure that patients with kidney disease live well. For example, one of the things I noticed in January, when Southern California was a war zone, and I ran out of dialysis machines because the entire hospital became ICU. If a patient has COVID-19, I was defending them not to be considered as lowest priority because we're running out of beds. And to tell them that these patients are full of hope. Otherwise, they wouldn't have chosen dialysis or kidney transplantation. Living well with kidney disease includes patients and care partner empowerment, live participation, and effective symptom management so that patients can feel well and supported. So with that, I would like to acknowledge colleagues at University of California, Irvine. We do a lot of dietary interventions, International Federation of Kidney Foundations. And these are my Twitters, Facebook, and LinkedIn. Thank you very much.
Well, thank you very much for this inspiring and interesting presentation. As it's quite clear that the kidney disease is a lifelong burden, and so we should tackle in holistically and look with 360 degrees and view, and this includes minimizing the burden of the disease, increasing participation in daily life, and improving mental health. So living well with kidney disease from the patient perspective means to have a fulfilling life despite the kidney health condition. So Raymond and Carl, what do you think? How can we improve this education, these choices, all that the things that you have shared with us?
If I can start answering, I think one of the problems is in education is that doctors have no time and also not always a good tie with their patients to give education. So there is always a kind of a gap that can be bridged by nurses, and I think that nurses should play, at least in the nephrology field, a more active role than is often done in European countries. The second point of education is, I think, the role of the home practitioner, who can really influence the patient, and but who himself is not always properly educated, for instance, about peritoneal dialysis, transplantation. Certainly in the older generation, they do not know that very well. So that's also an important point, I think.
Yeah, actually, just to expand on what Professor Van Holder has mentioned, it's important for not just the doctors, but the entire what we call healthcare providers to know about the goals. And it's connecting with the patient, of course, in a professional way, but in a way we understand beyond dialysis, kidney transplantation, or CKD clinic. Now, I've worked in Germany. I used to do a lot of moonlighting in dialysis units in Nuremberg, and then in New York and California. And I noticed it's everywhere is the same, believe it or not. That means there is a disconnect between us and what our patients believe in and expect. And not that it's always like that. When we round on dialysis patients as doctors, as nurses, we still do know and appreciate a lot of things, but we need to make it more systematically approachable and understandable. That means while inherently Dr. Van Holder is a good doctor and connects to patients, and I try to do the same, we need to be taught that these are priorities and we need to understand them in a systematic way so that we can teach younger doctors, nurses, everybody, right? So this is essential. I'm hoping that we reach some of these goals this year, 2021 and beyond.
Yeah, you are totally right. And of course, the core outcomes is quite clear. It's so different from the patient perspective for professionals. And we would like to go beyond the biomedical approach. So we are running out of time, but I have two questions and one comment. One comment is from Henrik that says that he's glad that here someone talk about something else that blood works or the analysis to measure what is good dialysis. No, this is one comment, and I think it's fine and it's good that to remark that. And we have another question about the COVID-19 vaccine. It is safe for immune suppression for immune suppressive patients because we are in immune compromised. Please go ahead, Cam or Ray.
Well, I can tell you, since in the US we started vaccination already in December, and it's now we are 3 months into vaccinations. In December already, I got my first vaccines, and then in January, actually in February, not January, in February, we started vaccinating all patients. In the 3 dialysis centers I go in, and our transplant center, 60 to 80% of patients are vaccinated. I can tell you the 2 vaccines that are currently available in Europe and US, that is Moderna and Pfizer, BioNTech, they are safe. They are not even live virus. Everybody should receive them. Of course, you may have reactions. And when I received my second vaccine, I was sick for 1.5 days. But those are not because you get a disease. It's because of reactions to what is injected to you. So it's not a live virus, and it's okay for all transplanted patients and all dialysis patients to receive. And not only it's okay, they should. So please find a way to give yourself the highest priority and receive the vaccinations, especially the 2 types that are available, and both of them are good. There's none of them is better than the others or worse than the others. And then in the future, as the other 2 or 3 are becoming available, some of them are based on live virus. As far as I was heard, they are also safe.
I just may add that one of the problems is that transplant patients and kidney patients are not included in clinical studies, and that's really a problem, because then we are working in the dark as doctors. So that is also something we have to work upon change.
Okay, only one final remark about the one question. Angeles is asking about the increasing psychological support. What do you think to improve the mental health and emotional disorders, as you know very well, is affecting patients? What do you think, Ray?
I can only agree with that. I think it's very important, but it's not reimbursed in most, at least in the Belgian system, it is not reimbursed or sporadically reimbursed. So that's a real problem. So then you have to pay it as a unit yourself, and then the hospital makes a problem. I don't know how it's in the States, Sam. Can you explain? Do you have better experience over there?
Well, I think, we don't have actually, that's maybe we want to push for something that governments and states to bring reimbursement for that part. That means life participation. That means, let's say the government of Spain covers dialysis, government of Germany covers transplants, immunosuppressive medications. But what about support groups, right? And in some states, in Germany, there is some coverage. How we can make sure that these activities, let's say if you, for example, Daniel, you spend so much time, how could your organizations even receive reimbursement from the government of Spain? And you guys provide that, similar to, so because I believe that at the end of the day, patients like Mr. Alan Henry Nelson highlighted, the one who lived 8 years with dialysis and showed that dialysis is hope, or kidney transplant should be offered to everybody. That lady behind her, they need to find time to do this, because these patients can tell you the story better than me and other doctors or nurses. So it has to be from patient to patient, and patients who are designated for this sort of education should receive support from the state and government.
Well, thank you very much for your valuable opinions and thoughts and ideas. And yeah, we are at the end of the first roundtable. So please feel free, Raymond and Carm, to remain in the webinar. I'm going to give the floor to Emily Petrides, who is the Vice President of the European Kidney Patients Federation. She's going to moderate the second roundtable with dear friends, and colleagues of the another kidney patients organizations, and also patients and transplant recipients. So they are going to give us the patient perspective of what does it mean living well with kidney disease. So please, Emily, I know, are you ready?
The only thing is that I don't have the camera.
Okay. But is not working, or you have a problem, a technical problem?
I think I can't even find the button for it.
Okay,
for some reason.
We can hear you very well. So the important is your voice. So please go ahead, and thank you very much for your time and being here.
Yes, can you give me just a second to try and
Okay, I don't know if we can enable your camera from here. We are trying to do that, and in the meantime,
start my video.
Yes. You are ready. You are now ready. Okay, Emily.
Hello, everyone. It's a great honor to be here today among fellow patients and advocates of chronic kidney disease patients. And as the theme of chosen for 2021 World Kidney Day is living well with kidney disease, I'm here today in the company of fellow patients who also had the strength and stamina to get involved and become advocates for kidney patients for the greater good. So it's a great pleasure to moderate this roundtable and to present everyone to you, starting with Fiona Loud, who is a patient herself that underwent dialysis for 5 years and then went through transplantation with a kidney donated by her husband. Fiona is Policy Director of Kidney Care UK, which she is also a member of EKPF. Fiona, hello. Nice to see you.
Hello, Emily. Hi.
Let me first introduce the rest of the team, and we'll get back to you. Next, we're going on to Colin White, who is the National Projects Manager for the Irish Kidney Association, a member of the EKPF as well, and a husband of a kidney patient, which I believe will give us a great feedback for the support a kidney patient needs to have by the immediate family. Now we go on to Jan van Gruchen, I don't know if I pronounced that correctly, who holds the position of Secretary of EKPF and also the President of the Dutch Association of Kidney Patients. Jan is also a patient that underwent peritoneal dialysis and now is transplanted. Hello, Jan. Can you hear us? Yeah? Can everyone hear me? Yes? Okay.
Yes, we hear you.
Yes, next we move on to Paulo Zoyo, who holds the position of Secretary of the Portuguese Kidney Patients Association, a member of EKPF, but also a patient that undergoes dialysis. Hello, Paulo.
Hello, everyone.
Hello, Paulo. And last, allow me to introduce myself as well. I am Emily Petridis from Cyprus. I currently hold the position of Vice President of EKPF and the position of President of the Cyprus Kidney Patients Organization. And I am also a patient that have received the kidney from my mother 13 years ago. Now, living with kidney disease and living well with it, it's a huge subject, and it has many parameters. Firstly, I would like to start with the diagnosis of the disease and how important it is to have the support of the family in this phase, so everyone can understand what this change means. And I think it's good to start with Colin as a family member who had to go through this with his wife. Colin?
Thanks, Emily. My wife was what's often described as a parachute patient, very last minute diagnosis of end-stage kidney disease. We were living in Zimbabwe at the time, and she had been ill for a very long period and was just getting worse, but they couldn't identify what it was. I think we got through 14 different consultants until we sat in front of a nephrologist, and the nephrologist started, we started explaining symptoms, and the nephrologist finished explaining the symptoms, and we knew that we were in the right place. I think, as with any illness, when you're first hit with it, it's quite a blow. You've got end-stage kidney disease. Like, that word "end" is kind of knocks you out fairly quickly. And the reality is, the first appointment you hear this, you don't hear too much after they make that sentence, because you're wondering, like, is your life over? What's going to happen next? Working with the Irish Kidney Association, we see this regularly. We have an accommodation facility beside the transplanting hospital, and so we get plenty of patients passing through. And yeah, that first diagnosis, they come in, and thankfully all of our staff are in that center are all transplant recipients themselves, so they can kind of break it down for them and kind of give them an idea of the lived experience. And I think that's where patients and family members can really come in value. It's what is the day-to-day lived experience? I remember sitting in front of one doctor many years ago with my wife. We walked into the consulting room, and he was reading the folder, and he said, "I see you're doing very well." And he didn't even look up to sort of see who we were. It was just a bunch of numbers on a page was describing who we were. But I think over time with that doctor, myself and himself in some ways developed quite a good partnership, because my wife was living with the illness, but I was witnessing the illness. So I could give that kind of third-party reiteration or focus that it's, yes, I've noticed my wife has slowed down, or I've noticed my wife struggles going up the stairs, or I've noticed this, I've noticed that. And I think that is invaluable in the treatment process, that you've got somebody who knows the patient that well that they're picking up on all of these small nuances.
So after that, what comes next? I think good adherence to treatment is the next thing we should be talking about, because many patients begin their treatments with denial, aren't they? So they're not. I don't think many patients follow the exact orders the doctor give at first. They don't understand maybe the seriousness of the disease, do they? Who would like to go? Fiona? Sorry?
Yeah, thank you, Emily. I suppose one thing that Colin just said really struck me very strongly, which is that I'm not a kidney, I'm a person, and I'm a person who has so many dimensions. I happen to be somebody with kidney disease, but I'm also a mum, a wife, somebody who works, and all those other things as well. And so your question there about adherence comes when we are first told that we have kidney disease, and when we are first given that information. What we are often not given is empowerment to understand what is being asked of us and why it is being asked of us. And it becomes very difficult then to, for example, people are often told this many hours of dialysis, and people will sometimes at first when I was on dialysis, I noticed everybody aimed to have as little dialysis as possible because they couldn't bear being in the unit. And now I know that actually having as much dialysis as possible is much better for you, for your long-term survival. But that's not how people perceived it. And it was because people didn't understand that the impact on your heart and all those things will help you live a longer life with kidney failure. So that was one thing. And I think that, so when we were first told about this, something about what does it mean to me and what can we together do about it? And if we're not given that information and education and a conversation over a long time to fulfill that partnership, we're not going to be able to be empowered and feel strong enough to be able to deal with it. Because after all, the bit where you're getting treated is only a small part of your life. And so that's, I do think that's something we can learn from. We've probably learned that over the years, but others should be able to learn from that. So using our experience, listening to us and acting on that is incredibly important. And so we're part of something called the Patient Reported Experience Measure Survey. That's an annual piece of work that's done in the UK. And that does ask people what their experience is of kidney care. And that's something that we want to have more people who are treating us to listen to hear about and to be able to act on, but together, because it's something we can do together.
I come across patients sometimes that refuse to understand the eating habits of a dialysis patient. And that, I think, is something really important we have to tackle now and discuss even more if other patients are listening to us. How dangerous eating the wrong food can be for a patient in dialysis. Paolo, what do you think?
Oh, hi, Emily. Hi, everyone. Thank you for your question. Well, yeah, that's a very, very thin ice subject. Well, as every kidney patient should know, high levels of particular potassium and water are the two main issues that should be very well controlled. And what I noticed as a kidney patient in dialysis for several years, some patients, they tend to enter in this depressive spiral, and the depressive spiral tends to make them look for some specific foods that are forbidden for them. So it's like a reward,
like comfort food, comfort food, yes,
like that, and forbidden food. So
of course,
because they tend on this depressive spiral, and they tend to abuse in some specific foods, fruits and vegetables, in particular fruits, and this is of course a nutritional issue that should be very carefully understood and followed by the nutritional stuff, but also for the psychologists. Because what I know, what I understand, that there's a lot of mental health going on in kidney disease, and in particular in hemodialysis, that is disguised by other factors. But going to educational, educational in what regards the nutritional aspects, I think the healthcare staff, and in particular the nutritional staff, should help kidney patients to learn about their limits, their boundaries, because they are. It's understandable that healthcare staff they have guidelines to follow, so they follow guidelines. But I'm not a guideline. My colleagues are not guidelines. So we have different boundaries. My limits are different than my colleagues. And healthcare staff, and in particular nutritional staff, should understand which boundaries each one of us have. So this is teaching the patient. Teaching the patient is not putting a book in front of me and saying that one banana have, I don't know, a certain amount of potassium. That's not teaching me. This is putting information in front of me.
It's not explaining what a banana can do.
No, it's how you do it, when you do it. You can eat a banana, but how and when you can eat a banana. So, but this means a lot of effort for the healthcare staff, and they don't have the time. I understand that. We have at least, well, as far as I know, in our system, nutritionists and healthcare staff as a whole, they don't have a lot of time to be with us, and much less to teach us something or to understand the needs of each patient. It's very, very hard to do that.
I think the best way to go about this is teach patients to be responsible, which is very hard because of all the restrictions they have in their daily lives, especially the dialysis patients.
Yes, but Emily, you should not. Patients are like children. If you forbid a children not do that, not, the children will do that, and that's not the way to teach a patient. It's not forbidden. It's you can do that.
If I could just maybe expand on that.
Yes, point. Of course you can all say your own bit if you want to.
What we found here, and I found it myself when I used to be a teacher, in terms to take Paula's example of getting responses from children, is rather than go the negative, rather than say you are restricted to this, you must not eat that, you must not do the other. It's looking at alternatives. We had a patient some years ago worked with some dietitians and produced top-class cookbook, not a leaflet, not a pamphlet, not a folder, a classy cookbook that would stand beside any cookbook in any bookshop anywhere in the world. Beautiful food photography, nicely written up, and all suitable for the renal diet, so that the family who are going to be impacted by the diet can actually get to eat interesting food as well, rather than Mammy has to have separate food, or we all have to have this food that's not really tasteful. It's it just kind of gives a bit more encouragement, because I remember when going first to patient education with my wife, and the dietitian would hold up this plastic symbol of a piece of chicken and say, this is the size of a piece of chicken you're allowed to have. It was just downright depressing. And the food side of healthcare for the patient is the one thing where they feel they want to have control, rather because they're used to it. I know how to prepare my dinner. So now you're telling me I can't prepare my dinner. It's removing all the aspects of control from the patient. So it's about arming them with the how-to rather than the how not to. And equally, it's about, where possible, tying symptoms and actions together. Like it's talking about the mad itch. Like what can I do to alleviate this itch? Well, it could well be diet associated. So if you'd like to remove it, if you consider this aspect of your diet. So they actually understand why they're doing it. They see the benefits of it, because the healthcare of this number should be between 5 and 12, and it's currently 3.2. you're kind of going, well, it's a number. It doesn't mean an awful lot to me. It's a number, it's outside its range, but how does that impact on my daily life? That, I think, is a major motivator for patients.
I agree with you, Colin. I think it really is. I used to dream about drinking water. I used to dream I was on a desert island and I couldn't drink water. That was how much, when something's taken away from you, and the fluid thing is really, really important. But the empowering thing is something that we didn't do well in the past. We are able to do more now. I'd like to share another example. We have at Kidney Care UK, we have a thing called the Kidney Kitchen now, which is menus for all the family. So it's a YouTube channel, and it's actually, you can see chef cooking the food, so you can actually cook the food along with it, and it's all got the sort of the things that you should perhaps take care of. So use herbs instead of salt, and all those kind of things that many of us we now know. We now know that they're important, but we didn't know that in the past. So we should learn from the work that people like us and the charities are all doing, so we don't have to have the next person come along and say, right, I've been told no salt, so I'm going to go with this salt replacement thing, which happens to be full of potassium. And that's something that I did. But that's the kind of thing, so not to repeat that, but to use that. And so the example I just gave with our Kidney Kitchen, that's got recipes from, like the African Caribbean community and different communities as well, because people will be interested in new things. And they've been tried out on families who like them, and they look nice. And so it's a bit more of a kind of, what can you do? Not what can't you do, because what can't you do is absolutely going to cause people to go up the wall.
Yeah, because it's too much.
It's too much all at once.
It's too much. Yeah. To take it all in, accept it, and change your life overnight, you can't. Yeah. So Jean, we haven't heard your voice yet, and you've been through two different type of treatments. You've been through peritoneal dialysis, and you had your transplant. What keeps you going? I want to talk a bit more about the healthy lifestyle. What makes us stand this and live with it, and have the power to move on and continue.
Okay. The first step is what Colin already said. When you hear that your kidneys doesn't work, the first thought is that the world collapsed, that your world collapsed. You don't know what is going on. You don't know what dialysis means. You don't know what transplantation is. And if it is possible to get a transplantation, you can't oversee what is coming on to you. And very important is that you call with that you talk with your doctors, but also with the nurses, and also with other patients who are a little further in that process, who are already on dialysis, who are already transplanted. And you see that they can have a life, that they are living. Mm-hmm. And then you get the hope, what also is said this afternoon, the hope that it is coming, good, that you also get a normal life. That is what you want, a normal life, and so normal as possible, being fit enough to work, have a family life, have a social life, that you can do physical activities. And I've done at first. Yes.
The physical activity is a very important aspect.
It is also very important for your disease, but it is also important for your life, to have a happy life. And when you start with dialysis, I first started with peritoneal dialysis, and that was working very good in my situation. at least the first years. I've had 2 transplantations, one after 2.5 years and one after 5.5 years. The first one went wrong, and then you have to go back to dialysis. And at that time, I've also done hemodialysis. For me, peritoneal dialysis was far better than the hemodialysis. But sometimes you have no choice. But what is going on? Yeah, you want to live. You want to, the impact on your family is enormous, to your wife, but also to your children. They have a father. Yeah, they have a half father or a quarter father in one time, and not the father they want to have. And yeah, you want to go through, and you want to do the things you have every time done. In my situation, I couldn't work. I had to quit my my work after 2 years. I could get a transplantation. That was luckily, but also the financial impact. What is going on? Can you stay living in your house? How is that? Happily, it could, was possible. And yeah, after the transplantation, the second transplantation, that is now for 5 years. 5 years ago, it went also very well. But you are always uncertain what is going on, especially in this time of COVID. As kidney patients, we are 3 or 4 times more. We get 3 or 4 times more troubles, big troubles, and also that same time more chance on passing out because of the COVID. So you live in a free quarantine in our situation.
Yes.
And we are not, at this moment, we are not vaccinated. Maybe in the next months that it is possible for the patients, the kidney patients in the Netherlands, to get vaccinated. I hope that it comes, and that we get also now in the COVID time a normal life back. I got a reasonable normal life back after my transplantation, and I hope now after the COVID I also get a reasonable normal life back.
They're telling me that I have to wrap it up in about 5 minutes time, but I want to stress out the fact that mental health is the key to me. As a patient myself, I've been a patient since the age of 16, very young. The denial, I remember, of accepting this condition was, it took me years to accept it. And what helped was a psychologist in the end. Many patients are ashamed to visit a psychologist, to ask for a psychologist, to ask for help. But I want to stress how important it is. If you're more balanced mentally, then I'm not saying you will be able to overcome everything, but it will, it will create the perspective you need in order to endure this. No? Yes, Colin.
Just going back to a point that Jan made earlier about the impact on the family. My wife went through a huge guilt trip after, like in the year after her diagnosis, because it turned our lives upside down. We were living in Southern Africa. I had the dream job, and we had great plans ahead of us. and everything changed literally overnight. And so she was, "I've ruined your life. I've destroyed your life. We were newly married, bright future ahead of us." But we agreed that she didn't bring kidney disease into the marriage. It wasn't kind of part and parcel of the deal. It was, we viewed kidney disease as almost like a third partner in the marriage. It's an unwelcome partner, but it's there. And from a carer perspective, what has been huge for me over the last 20 years she's been on dialysis is that she is always open and honest with me in relation to how she's feeling, how her health is, because the anxiety from a carer's perspective is what's going to happen, what's happening with them now. I can't carry the burden of dialysis for a week, a month, give them a break. And if you kind of get that feeling that maybe they're starting to hide some things from you, it actually makes it doubly hard, because they're not protecting you. They're allowing ideas to just build up all over the place. So we've agreed to be very, very open and tackle it as a partner. It's, we have kidney disease. Yes, my
unfortunately, this is not the case everywhere. So your wife is a really lucky woman, Colin, to have you.
But no, I would advise that it does, from the carer's perspective, it makes it a lot easier for me, because I feel at least I'm engaged in it somehow, that I can assist in some way, at least on the mental health issue that you raised yourself, that just kind of looking after that, looking out for that for both of us. And as I say, attacking it in a partnership form that together we can get through it.
Yeah, I know.
Fiona,
I have to wrap it up. A quick comment from everyone, please.
Okay, so just really quickly, completely agree about the mental health. It's okay to ask. I've been very lucky to be supported by my husband and my family, but I know that many people aren't. So counselling, there is counselling available through charities. Some of the charities like ours are able to give that. But and we also have to recognise that the massive impact of the pandemic, even on those who are kind of quite stable from day to day, because we've spent a year probably in self-isolation. So vaccination is of course the way out. It is a start of the way out, should I say. And we've been very fortunate in the UK that many of us have already had our first vaccination. The second one is coming. And I should just say that for us, the AstraZeneca vaccine is equally recommended. We have 3 available, 2 being used, which is the AstraZeneca and the Pfizer one at the moment. And some studies in efficacy have already started here. So I just wanted to let people know about that. So that's
you have been vaccinated with AstraZeneca?
No, I had the Pfizer one as it happens, but one of my husband, who's caring for me, he's had the AstraZeneca one as it happens. So, and that we're all completely happy with that. And there have been about 2 million people who are clinically extremely vulnerable, which includes thousands of kidney patients who've had either of those 2 vaccines already in the UK. And so people can check out our website for more info on that, because I just thought it was really important to quickly get that in for the audience.
Thank you. And I want a quick positive note for our patients listening to us from the rest of you.
The world doesn't collapse when you get the diagnosis you have a kidney disease. There is hope and there are possibilities, and we hope that the possibilities get greater the next years.
Thank you, Jean. Thank you. Paolo. Your speaker, Paolo. It's off.
Yeah, like Jan was saying, hope is fundamental. When a kidney patient or a chronic patient is diagnosed, he loses his sense of hope, and it's very and this is vital for the mental health issue. So patients need to have focus to an objective. So that's why some activities like the World Kidney Games, etc., gives something for the kidney, for the patient to fight about. Mm-hmm. So that's very important. So this is this for wrapping up the issue of mental health and for hope. So this is like a big bundle.
I think we should do this often because there are so many aspects we need to discuss. So we didn't have enough time. I'm so sorry for this.
Yeah.
Colin.
A very dear friend of mine, a transplant recipient, he joined our sports team when he was on dialysis. And he memorably said, after his first time of meeting fellow patients socially, he realized that his life wasn't over, it was just different. And I just thought, beautiful way of looking at it. And I think that's what peer support can bring to it, that you can see others who are getting on with it and who are achieving, who are reaching life goals. And like the beautiful things we're seeing more and more nowadays is people going on, like younger people going on to have families post-transplant. Like before it used to be getting to see your grandchildren post-transplant. Now we're talking about getting to see your own children post-transplant, which is such a wonderful thing.
On a closing note from me as well, the other day I had to take my transplant medication in front of a friend. And her reaction was, how can you stand doing this every day? And how can you stand living like that? With so many restrictions in your life and, you know, being always afraid of something happening to you, getting ill, rejecting the kidney. How can you live like that? And I turned and looked at her and said, well, this is my life. This is my life. And, you know, the illness is not going to beat me. I do the best possible. By saying the best possible, I mean, I take care of my my diet, which is number one for me. Exercise as much as I can, when I can, and feeling good mentally, which is, as we said, as we all said, I think it's the most difficult bit. That needs to be taken care of at all times. And our patients should not feel afraid to ask for the help they need when they need it. Well, guys, thank you so much for your time. I need to pass the floor to Danny. And Danny, can you hear us?
Yes. Sorry, because we
needed more time for this.
Yeah, we need. I will remain here and listen to all of you for ages, but we don't have more time, unfortunately. But it is quite clear for the conclusions that the kidney disease is an unknown path, and we are trying to enlighten the patient journey together with the professionals and with the patient organization and National Kidney Patients Organization, and of course EKPF. And of course, I see in the future that we need more conversations. Health are conversations. Every patient is unique. Every patient is a survivor. So we need to tackle, of course, from different parameters to different options, and to increase the knowledge about our needs, our unmet needs of the chronic kidney disease. So thank you very much for your time, for being here. We keep in touch. Hopefully, we will see each other in the annual summit at the end of the year in a face-to-face meeting. We'll see what happens with the vaccination process. But we are claiming for that, of course, in every country. And thank you very much for your fight, for being a very advocates of the kidney disease, and we are more than happy to work together with all of that. Thank you very much for the audience, for this very fruitful conversations, ideas, thoughts, and we keep in touch, of course, to the EKPF members, and we will set up a new webinars during this year. So thank you very much. Stay safe and a lot of kidney health for everybody. Bye bye.
Bye.